Good morning, everyone. Good morning. Welcome back to the 2019 Conference on Metastatic Breast Cancer with Living Beyond Breast Cancer, to our final day here. We're very happy to have you back. And I'd also like to welcome back our web stream audience. Let's give them a big hello this morning. Thanks for being with us wherever you are. My name is Janine Guglielmino, and I'm Senior Director of Programs and Partnerships at Living Beyond Breast Cancer. We're pleased to have you back today. So this session is on the effect of physical activity on cancer treatment and outcomes. And we're going to take questions throughout. So I want to give out the text number now for you to put in your phones in case you'd like to ask questions. It is 610-365-7532. And as always, we ask for you to try and ask your questions in a generalized way so we can share as much as possible. Also wanted to mention, if it hasn't been mentioned to you 100 times already, we'll be emailing you evaluations after the program. We really read every single one of them, and that includes those of you on the live stream. We include your feedback in designing future programs. So please look for those and fill them out. With that, I'd like to introduce our speaker, Dr. Lee W. Jones, who's Director of the Exercise-Oncology Service at Memorial Sloan Kettering Cancer Center. Dr. Jones's lab at Memorial Sloan Kettering researches how exercise affects cancer growth or could affect the way the body responds to standard and new therapies, and looks at exercise in terms of dosing and how much would we need for it to have an impact. So I'm really excited to have him here today, and I'd like to invite him to join me on stage. Let's give him a warm welcome.
Okay. Okay, can everybody hear me okay? Excellent. Well, morning everyone, and thank you for the invitation. It's an absolute pleasure to be here. I really thank the committee for inviting me to present on, I think, a topic that I think sparks a lot of interest in many of us. Of course, we all went to the yoga session this morning. Now we're sitting down to listen to an exercise talk. Of course, that's great. So my name's Lee Jones. I'm a PhD in exercise physiology, but I run a research program at Memorial Sloan Kettering that just concentrates on investigating the role of exercise after a cancer diagnosis. That's all that we do. So my background was, I don't have a New York accent, as you can probably hear. I was born and raised in the UK, and then I was in Canada for about 8 years. Then my first job was down at Duke University for about 8.5 years, and I've been at Memorial Sloan Kettering for the past 5 years. So that's my background. So there, like I say, I run a research program. There's about 26 of us in this research program, again, all just looking at the role of exercise. So today, I think I'm going to be a little bit different than the typical exercise talk, and hopefully that will become very apparent as I start going through this talk. And if I'm talking too fast at any time, just do this, tell me to slow down. I'll try my best, but sometimes I get a little bit excited about the things that we're doing. And again, the approach that we take is a little bit different. And so it might seem like we're going off tangent a little bit from time to time, but believe me, I'll come back in. But I want to give you guys the real stuff. This is about close-up on research, so I want to give you the latest research in this area of study. So I'm going to start with a bit of a history of this area that we call exercise-oncology. So I can tell you this name, exercise-oncology, is something we made up. It didn't exist like 20 years ago. It just did not exist. So if you think about, we hear a lot about the role of exercise in things like diabetes and cardiovascular disease and things like that, but rarely do you see exercise and cancer in the same sentence. So when I moved to Canada from the UK, like back in 1998, I was studying at a place called University of Alberta in Edmonton, which is kind of northwest Canada, absolutely freezing, by the way. Don't go there in the winter. Or actually, just don't go there until June or July. Just go there June, July, no other time. So at the time, we're interested in doing something a little bit different. And so we started to think about, what is the potential role of exercise in individuals who have been diagnosed with cancer? So we looked into the literature, and we found 2 studies, just 2 studies that looked at the role of exercise in individuals with cancer. And actually, the first study was published in the late 80s. Actually by a couple of nurses at Ohio State University, and they looked at the role of exercise training in women who were going through chemotherapy for early stage breast cancer. That was the very first study ever to look at exercise in women with breast cancer. So we started to talk to our oncologist friends and colleagues about, we want to start looking at the role of exercise in cancer patients. And they thought we were crazy. They thought we were crazy. Like, Lee, do you realize that these individuals are going through treatment? They don't feel so good. The last thing we want to be doing is exercising these individuals. But we thought, with my physiology background, we thought it could be incredibly beneficial. But the oncologists simply wouldn't buy it, which is kind of interesting. It's actually kind of similar to what happened in cardiac disease 50 years ago. So if you had a heart attack 50 years ago, the treatment at that time was 6 weeks of bed rest. That was the treatment 50 years ago. Now, as many of you might know, if you have a heart attack today, then exercise rehabilitation, exercise therapy is the first line of standard of care for individuals, and you exercise in the day after your surgery. So from many respects, oncology was 50 years behind where cardiology was. So we eventually persuaded some of our colleagues to do some of these early studies, and it turned out, of course, that it was beneficial. Individuals were reporting less fatigue, not more fatigue, higher quality of life, improvements in things like physical functioning, things of that nature. But we really had to start at the very, very beginning of this research. So what I'm going to tell you about today is really what's happened over the past 20 years, which is not a long time in research at all, but I think we've come a long way. So the second kind of large study that was published was in 2001, and this was a Canadian study from Ottawa. And this was a landmark study. Again, this was in the context of women with early stage breast cancer going through chemotherapy. But this study was important because it was published in one of the biggest impact journals that we have, called the Journal of Clinical Oncology, which is the official journal of the American Society of Clinical Oncology. So this is read by oncologists all over the planet. So this really was a first study to put exercise, if you will, on the map in the oncology setting. And then many of you may know, you might not know this, but in 2003, the first exercise guidelines came out for cancer survivors. So that was in 2003, so it was a while ago. We didn't have very much evidence at the time, but those guidelines came out. And essentially, those guidelines were the same as all the guidelines for healthy Americans, which I know all of us are doing, so I don't need to reiterate that, but it's about 150 minutes of moderate intensity exercise per week. The guidelines for all Americans were the same for cancer survivors. So, and then in 2005, a really important study came out, not performed by me, but by somebody else, actually by Michelle Holmes. It was at Harvard, at Dana-Farber. And this was the first study to look at the relationship between exercise and cancer outcomes. So all the other studies up to that point had looked at the role of exercise to help control the symptoms and side effects of cancer treatment. This was the first study to look at whether exercise could improve outcomes, cancer-specific outcomes, i.e., could exercise delay the risk of recurrence? Could it delay the risk of dying from breast cancer? So this was the first study to look at that question. I'm going to come back to that study a little bit more in a minute. So that was a kind of a really important juncture in the field of exercise oncology, again, because it was the first study to go beyond can exercise just help with symptoms, but can it actually impact the trajectory of the disease itself? The second study was published a year later. This was by Jeff Meyerhart, also at Dana-Farber, but this time it was looking at the relationship between exercise and cancer outcomes in individuals diagnosed with colon cancer. So I'll come back to that study in a second. And then in 2010, the American College of Sports Medicine, which is like the big organization for exercise physiologists, also published exercise guidelines for cancer survivors. Those guidelines have just been updated, actually. They should be released later this year. And then in 2014, I published a study. This was not a landmark study at all, The reason, because we looked at all the literature at that time and what the kind of studies in exercise oncology were doing. And what we found is that the majority of the studies are still focusing on the role of exercise to help improve symptoms, toxicity of treatment. That's where most of the studies are really looking at. Can exercise improve quality of life, fatigue, physical functioning, that type of question? Only about 10% of studies are actually focusing on, is exercise an effective form of treatment for cancer itself? Now today, I'm going to focus on those 10% of studies. I'm not going to talk at all, well, not very much, about exercise to help with symptoms and things like that. We can talk about that in the Q&A, but I'm really going to focus on exercise as a form of cancer treatment itself. I think that's the really exciting, actually, some of the things that we're doing. So I'm going to concentrate on that. That's not to say, of course, that exercise is not beneficial for things like quality of life and fatigue, but we can talk about that after. Does that sound okay? Well, that's my presentation, so I guess I can't remake it. So if you look at this area of exercise oncology, so this is globally what's happening. So a lot of the early research was in Canada and Alberta, believe it or not. But this was just all the countries of origin of publications published in 2018. And what you can see is this now research is going on all over the planet. So just in 20 years' time, it's gone from just this little field. Now there's papers coming out every single day. I was just online this morning. I check every single day to see what new papers have come out. There was actually 3 just this morning. So this is a rapidly growing area of research. We probably now have about 250 studies that have looked at the role of exercise in individuals with cancer. That sounds like a lot, and it's certainly better than we were. But that compares to about 3,500 of exercise studies in things like cardiovascular disease. So we've got a long way to go, but I think we're making good inroads. So what is the evidence? What is the evidence to suggest that if you exercise after a cancer diagnosis, I'm going to focus most of my talk on breast cancer, but I'll throw in some other types of cancer as well. So what is the evidence that if you exercise after a cancer diagnosis that it can impact things like risk of recurrence and other things, like these really, endpoints we typically think about, like receiving different types of conventional cancer treatments for? What can exercise can do? So this is the study I mentioned at the beginning. This was one by Michelle Holmes, published over 10 years ago now. So this was looking at the relationship between self-reported exercise and women diagnosed, and about 3,000 women diagnosed with early-stage breast cancer. And then looking at these individuals of how much exercise they reported and comparing their risk of their cancer coming back, of their breast cancer coming back. So what they did in this study is they basically give questionnaires to all of these different women, and they asked them, how much exercise have you been doing over the past kind of 6 months or so? So women would report either doing nothing, doing something, or doing a lot of exercise. So what you can do with that, you can characterize these different levels of physical activity and exercise. So what Dr. Holmes did is she compared those women who reported being sedentary, doing absolutely no exercise whatsoever, and she compared to those women who were doing about 9 to 14 met hours of exercise per week. I'll put that into different language, if you will. Basically, those women reporting anywhere from about 150 minutes of moderate intensity exercise all the way up to about 250 minutes a week. So that was the category. So comparing those who did nothing versus those who did, if you will, meeting the exercise guidelines. So in those women meeting the exercise guidelines, they had a 50% reduction in the risk of their cancer coming back. A 50% reduction. I will repeat it. We have our first question. Pause.
How was exercise defined? What kind of exercise were the participants doing in this study?
Great. I don't need to repeat it, right? Because everyone, okay, beautiful. So the types of exercise it's all different types. So this could be swimming, it could be biking, it could be walking, it could be running. But I can tell you from the studies that we've done, we know that about 80% of all, at least women with breast cancer, are reporting walking as their primary form of physical activity and exercise. But that doesn't mean, I can get into this a little bit later. Walking is great, but so is swimming. I don't care what exercise you do as long as you do it. Preference. So a 50% reduction in the risk of recurrence, that's pretty good. That's pretty good. So just, I know we've got some guys in the room as well, just to say in prostate cancer, this research has also been done. Again, this was in a study. It was published quite a few years ago. About 2,700 men with prostate cancer, essentially doing the same thing, comparing those men who reported being inactive compared to those men reporting kind of meeting the guidelines. There was about a 35% reduction in the risk of prostate cancer coming back in those who are exercising compared to those who were sedentary. And then in colon cancer, again, comparing those who are sedentary compared to those exercising, about a 50% reduction in the risk of their cancer coming back. So now we have 3 studies all showing that if you exercise after your diagnosis of breast, prostate, or colorectal cancer, there's pretty significant reductions in the risk of cancer coming back. Now, this is a little bit small. You might not notice this, but what's interesting, in the first study, you needed about 150 minutes of exercise to get the significant benefit of exercise. In the second study, that range of exercise ranges from about 150 minutes of exercise up to about 450 minutes of exercise per week to get the same amount of benefit. In the final study, it's actually about 500 minutes of exercise per week to get the same amount of benefit. So across these different cancer types, you need a different level of exercise to get this significant reduction in cancer coming back. And I'm going to come back to that a little bit later. We often think that it's just one dose of exercise you will and you get all these benefits, but that might actually not be true. Okay, so that was just 3 studies. So since that time, there's now been about 19 studies, these observational studies, I'll describe to you what I mean by that in a second, that have looked at the relationship between exercise reported after diagnosis and the risk of dying from cancer. Most of these studies have been in the context of breast cancer, about 10 studies, fewer in colorectal cancer, and also 3 studies in prostate cancer. Now, if you combine all these studies together, there's about a 37% reduction in the risk of dying from cancer in those who are reporting exercising compared to those who report being inactive and being sedentary. If you look at the risk of relapse or recurrence, there's only 8 studies that have done that. But again, if you combine all these studies together, there's about a 35% reduction in the risk of your cancer coming back in those who report exercising, compared to those who report being sedentary. Okay, so now, this is observational data. You have to take this observational data with a little bit of pinch of salt. So these are the papers that you read about maybe in the New York Times and things like that, say, oh, don't eat salt because of X, Y, and Z. Or I think there was a paper out last week saying that if you have 2 eggs a day, it increases your risk of X, Y, and Z. Now, you have to be a little bit careful with these studies because they're not cause and effect. They're an association. So we're asking people how much exercise they do, and then relying on those individuals to report accurately how much exercise they do. Now, typically, we over-report how much exercise we do. We might under-report our weights. It just kind of happens. It happens to the best of us. But also, not all of us are going to be able to accurately recall exactly how much physical activity we're doing. And maybe moderate intensity exercise, to me, means something completely different to somebody else. So when you do these studies, this is a guess, essentially. It's an estimate of how much people are doing. But it's not very accurate at all, because it's just an association. So when you see these studies that report and it says, oh, there was an association between, as soon as you see the word association, don't think garbage, but think, I don't really know if that's true or not. And often we take this as being fact, and it isn't. So we have all these studies, but this does not prove that if you exercise after a breast cancer diagnosis, that you're going to get improvements in cancer outcomes. It doesn't prove that at all. It just says there's a signal. There's a signal there. The way you can prove it, of course, is by doing these large randomized control trials. So there are a couple of trials that are going on right now. Unfortunately, none of these are in breast cancer right now. There's a large trial going on in the context of colorectal cancer. It's called the Challenge trial. This is out of Canada. This is an international phase 3 randomized controlled trial. These trials are $25 million trials, massive trials. About 1,000 individuals. It's a 3-year exercise intervention going on across all over the planet. I think it's open at like 30 to 60 different sites across the world. Really looking at the question is, if we get individuals with colorectal cancer to exercise for 3 years, does that reduce their risk of their cancer coming back? So this is a head-to-head phase 3 randomized controlled trial. So that's ongoing right now. It's about 10 years into this study, actually. There's also a second study that's also just been launched. This is in the context of metastatic prostate cancer. This is about 900 men with stage 4 metastatic prostate cancer. And this is a 2-arm randomized controlled trial. So patients either get randomized to a control group or to an exercise group. The exercise intervention, I think, is about 16 weeks in duration, so a lot shorter. And this is asking the question, if we can get these men to exercise, can we improve how long these individuals live compared to a control group? So these studies are ongoing right now. So I just wanted to make you aware of that again. So the second study, interestingly, is funded by Movember. You grow a mustache. Well, the guys grow a mustache in November to raise money. So this is funded by that. It's about a $15 million trial. I'll just say, just disclosures, we're not, Memorial, we're not involved in any of these studies. And the reason for that is because we think about this a little bit differently. So if you think about this, and this is where we're going to get a bit geeky, we're going to get a bit sciencey, but I think this is really important when we're starting to interpret this data. So essentially, if you think about the way that these studies have been developed, essentially we've gone from this epidemiologic, this observational data that has its limitations, and we've gone straight forward into doing these very large randomized controlled trials, right? So we've gone from observational to randomized controlled trials, big randomized controlled trials. That's what we classically do when we test things like exercise or non-traditional therapies. So if this was a drug therapy, this wouldn't happen. But with things like non-traditional therapies like exercise, diet, acupuncture, things like that, this is typically what we do. So if you look historically at the way that these trials have been done, so there was a big trial some of you may be aware of. It was a breast cancer prevention study done as part of the Women's Health Initiative. So this was a massive study, like 48,000 individuals, women in the US, asking the basic question, if we do a low-fat diet in individuals versus those who just eat a regular diet, does that prevent the risk of getting breast cancer in the first place? And I think most of us would think, yeah, low-fat diet, that should make sense, right? Well, that was completely negative. That study is completely negative. Didn't work at all. OK, there was a second study that was published a few years ago that looked at dietary intervention in women with breast cancer, asking the question, if we improve diet in these women compared to just a regular diet, does that influence the risk of cancer coming back? Does it lower the risk of recurrence? And I can tell you that study was positive. That meaning it did appear that this improved diet did maybe decrease the risk of recurrence a little bit. And we think the reason for that is because these women lost a little bit of weight. But I can tell you there was a second study also done around about the same time, published a year later, asking the same type of question, and that failed. It was negative. So now, if you walk into clinic, because we've got these opposing studies, dietary recommendation, if you walk into clinic, is not part of standard of care. Because people don't know, well, does it work or does it doesn't? So we're left with a bit of a conundrum. OK, what about other things? So some of you guys might know these. There was just a large study a couple of years ago in patients with diabetes, asking, does a lifestyle intervention prevent cardiovascular disease in patients with type 2 diabetes? So in patients with diabetes, the risk of cardiovascular disease is up the roof. It's huge. So this asks the very simple question, OK, if we intervene with lifestyle, diet, and exercise, does this lower the risk of cardiovascular disease? It was negative. 5,000 patients, did not work. This is a $30 million trial, did not work. OK. Another trial just came. So by the way, these journals I'm showing, this is the New England Journal of Medicine. This is the top medical journal we have. These are not Bush League studies. These are the randomized control trials. Okay, another study just came out just actually about a month ago. You might have seen this in the papers, testing the effect of giving people omega-3s on the risk of both cardiovascular disease and cancer. If we give people omega-3s, omega-3s really good, right? We hear that all the time, and they're very good for you. If you give omega-3s, does it prevent cardiovascular disease and cancer? 25,000 person randomized controlled trial that failed, didn't work. If you take omega-3s, according to this study, it doesn't prevent cardiovascular disease and it doesn't prevent any form of cancer. There was also a second study published at exactly the same time that looked at vitamin D. So if you take vitamin D, we hear all the time, you've got to take it. If you don't take it, the bad things are going to happen. This study tested vitamin D. Does it lower your risk of cardiovascular disease and cancer? Failed. Again, another study that's negative. And I could go on, by the way. We haven't had a vitamin trial that's been positive over the past 25 years. Not a single vitamin study has showed that it decreases the risk of anything. Now, this might sound all very depressing. I'm not just saying just go out there and eat all the muffins. I'm not saying that. But I'm not saying that. I'm saying something a little bit different. I actually think I think this begs the question, why do we have so many negative studies? I think you could raise the question, of course, that maybe these things are not beneficial. I think we have to acknowledge that, and they need to be tested. My viewpoint on that is a little bit different. I believe these studies have failed because we haven't answered very basic questions when we've designed these trials. The first thing is who are the individuals who actually need these interventions in the first place? Who are the individuals who are actually going to benefit from taking vitamin D, need a healthy diet? Or in my case, who are the individuals who actually need to exercise? Now, you could say that everybody needs to exercise, but I can tell you that people respond differently to exercise. I'll get into that in a little bit. So, the second thing I think you would ask me if I was walking down the street or I got stuck in an elevator with you, you would ask me, well, Lee, exercise is great, but how much do I need to do? What dose of exercise, and not for everybody in this room, but what exercise do I need to do? What exercise do I need to do? Right? So these studies have been designed, and we haven't known what the dose of the drug or the dose of intervention is needed to actually have benefit. So I would say, what dose do we need to actually really have an influence on these types of endpoints? And the final thing is, which you'd also ask me is, how does it work? Like, if you were doing any drug trial, you would know which patients are going to benefit, you would know what dose to give, and you'd know mechanistically how it works. But when it comes to kind of non-traditional therapies, when it comes to things like exercise, we rarely have the answers to these questions, believe it or not. OK, I'm going to pause. I've said a lot, maybe a little bit controversial. Shall we go? Do you have a question?
I do have one question.
OK.
Is there research on the association of exercise with progression in metastatic cancers or in metastatic breast cancer?
Not other than relapse and cancer-specific mortality, but not specifically progression.
When you say relapse, you mean a recurrent diagnosis?
That's correct.
OK, thank you.
Good? Can I go on?
Yep.
All right. Everyone's OK? If anybody needs to stand up at any time, please, this is an exercise talk. I'm not going to make you do jumping jacks or anything like that. Don't worry. And if you want to walk out, you can do that too. Please don't. OK. So if you think about it, the way that we've classically thought about these trials in design, we've kind of, again, we've gone back, we've done these epi studies straight to these phase 3 trials. But what we are doing is a little bit something different. What we're doing is we're approaching the development of exercise, the development and testing of exercise, like you would a drug, like a cancer drug. No, I'm not saying it's a cancer drug, but I'm saying the way that we're testing it is in the same way. So for us, this involves a number of different steps. It starts with the observational studies, that's step number 1, but then it goes through into preclinical testing, like animal testing, testing these things in animals. Is there biological effects in these mouse models that we use for the development of cancer drugs? Then you get into what we call safety and feasibility studies. You get into these early, what we call signal-seeking biological studies. And then if all of those steps work, you then get into the large phase 2, phase 3 randomized control trials. So this is the approach that we're adopting at Memorial Sloan Kettering. And we believe this will really facilitate the rigorous development of exercise as a cancer therapy. But I think just as importantly, it would hopefully answer these 3 questions that we think are fundamental for when we're designing and testing exercise, which is, who are the patients who respond to exercise, who needs it, what dose of exercise do we need to give, and how does it work? So for the next 50, 45 minutes, maybe 40 minutes or so, I'm going to go through each one of those 3 questions and talk about what we know so far about answering these 3 questions, and hopefully that will bring up lots of additional questions that I can take back to the lab. Okay, so which patients? This probably sounds crazy. You think that everybody benefits from exercise? Well, I'm going to give you some new data. So this is the data. This is called the forest plot. I will walk you through it. Basically, this is data that's looked at the relationship between exercise and risk of recurrence in women with early stage breast cancer. Now, each line represents an individual study. So there's a total of 5 studies. So the square represents the average risk reduction observed in that particular study. The line in between represents something we call the 95% confidence interval. Essentially, that tells us how confident of the effect that we see, how confident are we that if it's real. Now, if that line, the horizontal line, crosses the vertical line in the middle, that means it's not statistically significant. Anyway, we don't need to really get into that, but you can see here there's a lot of variability between these studies. They're not all shifted all the way over to the right. There's a little variability. The very line at the bottom is the average. If you put all these studies together, that's the average risk reduction. And so typically when we report studies, that's what we report. We report the average. We don't talk about the individual studies. But you can see there's a lot of variability between these studies. Now, I think the reason for this, it could be because the way that exercise has been measured across these studies is different. It could be that these cohorts come from Europe, some from North America, maybe some from Australia, so there might be differences there. But the reason I think there's differences and you don't see this uniform impact is because all these studies to date have looked at breast cancer as being one disease. Now, all of you in this room know that breast cancer is not just breast cancer. Breast cancer has many different forms of breast cancer. There's HER2 positive, there's HER2 negative, there's triple negative, there's hormone receptor positive. You guys know this, of course. I can tell you exercise researchers don't think like that. They don't. So for us, we put all these diseases together and said, okay, what's the relationship in general? So a couple of years ago, we did something that is very simple, that you guys would have thought about many years ago, but of course we hadn't. So we thought, okay, what is the relationship between exercise as a function of breast cancer subtype? If we just look at the same relationship, but this time we see the relationship, is it different as a function of different clinical subtypes of breast cancer? So this is the data. So this is all in early stage breast cancer. There was 6,000 women. Again, self-reported exercise behavior, so you can take that with a pinch of salt. But we put these women into the different 3 major clinical subtypes that's used in clinic. So that would be hormone receptor positive, HER2 negative, hormone receptor positive, HER2 positive, and then the final line there is triple negative. Now, I'll just walk you through this very quickly. What you can see here is it appears, see that blue line, the blue square? So that's women with hormone receptor positive, HER2 negative breast cancer. And it appears from this data that that's where the benefit of exercise appear to be confined. Now, the women with hormone receptor positive, HER2 positive disease didn't appear to have a benefit from exercise, and neither did the women with triple negative disease. I'm going to come back to this in a second. But this is the first data showing that you just can't say, let's look at the relationship between exercise and breast cancer. This data is suggesting that that relationship is different as a function of clinical subtype. We also looked at the different molecular subtypes. As you probably know, there's luminal A, there's luminal B, there's basal, and there's HER2 enriched. We really didn't see too much different, but again, it appeared to be like the luminal A tumors appeared to be the most sensitive, if you will, to exercise. Now, again, take this with a pinch of salt. This is observational data. I'm going to present you data in a minute that's going to, anyway, well, let's just keep going. How about that? Okay, So the next thing we did is we said, okay, we wanted to test this now in mouse models because we know of all the limitations that comes from self-reported data. What we want to do is, can we take advantage of a mouse models and uniformly test exercise just like you would a drug? So you might not believe this, but we have about 7 treadmills for mice in Memorial Sloan Kettering. You can run 6 mice at a time on these treadmills. And with that, I know, it's unbelievable, I get paid for this, it's crazy. With that, of course, you can control the dose and exposure to exercise. So you control the speed, the grade, and the amount of time that mice are on this treadmill. You're not just letting them run free. You're very much controlling it. So what we can do with that is we can really uniformly dose all these mice, and we can give them different doses. So this data is currently in progress. It isn't published yet. It hasn't been peer reviewed. So you can take it with a pinch of salt. But we asked a very basic question. Given these differences in our observational data, we then took 11 different types of breast cancer cell lines, 11 different types. And we injected these cell lines into mice that were either randomized to exercise or mice that were randomized to nothing. Actually, the mice that got nothing got something called sham exercise. We put them on the treadmill, but we don't turn it on. They just kind of just... Sounds cruel, but we want to make sure they get exposed to the same handling. They just sit there. Actually, they just run up and down the lane a little bit. But so the exercise in this case was treadmill running 5 days a week for 30 minutes at a time at about 18 meters per minute, which is a moderate intensity training program for a mouse. We know that because we test their fitness. So this is, if you will, the exercise guidelines. Now, we don't know what the exercise guidelines are for mice. Nobody's published that. But we know what they are for humans, and so that's where we started. So you can imagine here we've got these 2 groups, but we did this in 11 different types of breast cancer cell lines. And the breast cancer cell lines that represented all the 3 different clinical subtypes: hormone receptor positive, HER2 negative, HER2 positive, and TRP negative. So here's the data. So we can categorize the responses either being these cell lines are either responsive to exercise, meaning that the tumors didn't grow as fast when we exercise them, or we can classify them as being resistant. Is if they exercise, tumor growth was the same as in the control group. Does that all make sense? Okay. So this is the data. So I don't have to go through the individual cell line because we don't really need to get into that. But the important take-home messages here is, regardless of subtype, we had some cell lines that were responsive to exercise, and we had some that were resistant in the same clinical subtype. So I mentioned before that it appeared to be the hormone positive, HER2 negative that appeared to have the best benefit from exercise. Our preclinical data is completely contrary to that. And in fact, we have some cell lines that are very sensitive. We see about 30 to 40% growth inhibition of these cell lines just with exercise alone. Actually, it's kind of cool. But we see some lines in that same subtype that don't care if the mouse is exercising at all. They just grow just as fast. Exercise makes no difference. That's also true in HER2 positive, but it's also true in triple negative breast cancer as well. I just told you that triple negative didn't appear to respond, but we've got cell lines that do respond to exercise. So you see this kind of opposing data between what we're seeing epidemiologically and what we're seeing actually in the lab, where we can really tightly control and dose exercise. I think that's kind of interesting. I can tell you now we've got the next wave of this experiment going on right now. So people might say, well, Lee, the reason why these cell lines didn't respond is because the dose of exercise was not enough to affect the biology. So what we're doing, I've tripled the dose of exercise, and we're repeating it again. I can tell you so far, the results of this are holding, which means that it's fascinating. So even if you do like 450 minutes of exercise per week in a mouse that has some of these cell lines, they don't care. These cell lines do not respond. They do not respond. So what's fascinating about that is the biology, the actual mutational biology of these tumor cell lines is different. So now we're actually doing genetic screening of these tumors to see if there's a genetic signal that predicts the response to exercise. That's telling you that biology of tumors, of cancer, can maybe modulate the response to something like exercise, which I think is kind of exciting. We also just did another experiment. This is published, so you can take this. So this was just in triple-negative breast cancer. Based on our finding that triple-negative breast cancer didn't appear to respond, we said, OK, let's put this to the test. So in this experiment, we had 3 different types of triple-negative breast cancer. So all these cell lines are triple-negative, but they've just got slightly different molecular profiles. But they're all classified as being triple-negative. This time, we run the mice an hour a day, 5 days a week, 18 meters per minute. We've got these 3 cell lines. So blue is control. Blue is exercise. Red is control. In the first cell line on the far right, you can see that the blue box is below the red box. That means that exercise in that cell line significantly inhibited tumor growth. So it was a lot slower in mice that exercised in that particular cell line. In the second one, exercise slowed tumor growth, but not very much. In the third one, exercise did nothing at all. So now, it's even more complicated. Now we've got triple-negative cell lines, all different molecular subtypes, 3 different responses. Again, that is telling you that it's about the biology. We've really got to understand the biology to understand what exercise might be doing. OK, I'll pause there, because I need a drink of water.
That'll give me a second to ask one clarifying question about the slide with the subtypes.
Yep.
The HER2 positive, was that only HER2 positive, or were those cell lines HER2 positive and ER positive? Because someone was asking whether anyone's looked at the cell line that's just HER2 positive.
Yeah, not every cell line is just HER2 or just ER. I think they were HER2 ER negative, HER2 positive, ER positive, ER negative, sorry. Because if they're ER positive, HER2 positive, then it would have been in the first categorization. Does that make sense?
Yep.
OK. Are we all good? Everyone's OK? We're still awake?
If the hormonal positive is lobular or ductal?
Yeah.
So I'm going to repeat that question so folks can hear it on the live stream. Does it make a difference whether the cancer is lobular or ductal?
Maybe. We don't know. We haven't gone into that yet. We haven't gone to that level of nuance yet. But we're working on it. We're working on it. Great question. OK. So I'll just let you know that we think that the genetic profile of these tumors is very important. So we have a patient study on the go right now that we're trying to actually understand this at a patient level, not just in mice. So at MSK, we're profiling thousands of tumors on their genetic profile. It's called impact panel testing. That basically test these different types of cancer for about 465 different genes. So this is ongoing. We've done about 35,000. This was actually a $100 million effort. A lot of money to do this. So what we've come along and done is now we're trying to collect exercise information on as many individuals as possible that are going through this impact panel testing. So we can look at the relationship between exercise and things like progression and recurrence, and does that differ as a function of the tumor genetic profile? I can tell you, nobody's got this data on the planet. We have now about 3,000 patients where we have exercise and tumor genetic profile data. We're just about to start analyzing. This has been a big effort over the past couple of years to get this. And the way we're doing this is actually kind of cool. Where we don't have a person sitting in clinic. We actually email or text our participants, our survivors. We get them to fill out a questionnaire online, and then that comes right into our databases. There's also another part of it where we're asking individuals to put a Fitbit app onto their device, and we're collecting all the mobility data off somebody's phone. So not only will we have subjective information in terms of what people tell us or think they tell us they do, we're actually getting objective information as well from their Fitbit app. So this is ongoing right now. All right. OK, just to summarize that first part, it seems like exercise after a diagnosis, particularly a breast cancer diagnosis from the epidemiologic studies, might be associated with improvements in cancer outcomes. But I think our data shows that the molecular profile of tumors is going to be really important as we get into this a little bit. All the data so far doesn't prove anything. This is all hypothesis generating. But I think it does show that not all tumors are going to respond the same way to exercise. So hopefully that's new information. OK, I think a really important question as we switch gears is you'd ask me, okay, how much do I need to exercise for anything? So I'm going to go back to Michelle Holmes' paper, the one that was published in 2005. So this figure looks a little bit different. I wonder if I can use my mouse here. Oh, there we go. OK, so this figure looks a little bit different. So this is amount of exercise. So this is what self-reported exercise these women reported, and this is classifying this different exercise levels. So this is women who are reporting hardly any exercise, some exercise, moderate amounts, high amounts, very high amounts. Does that make sense? And this is the risk of cancer coming back. So essentially, if you go from women reporting nothing to those who report something, there's about a 20% reduction in the risk of cancer coming back. For those women reporting, as I mentioned, 9 to 14.9 MET hours, about 150 minutes, there's a 50% reduction in the risk of their cancer coming back. But you can imagine, you can see now those reporting high levels and very high levels, it didn't continue to get lower and lower. It actually plateaus a little bit and starts to go back up. So you've kind of got this U-shaped relationship. So that's kind of interesting because that tells you that in this particular study, doing more than 150 minutes of exercise per week did not give you additional benefit in terms of at least the reduction in the risk of breast cancer coming back. Now, often we always hear more is better, right? We need to do more. If I was talking about cardiovascular disease, it appears that sky's the limit. The more that you do, the better the benefit. This data suggests that is not true when it comes to things like breast cancer recurrence. Does that make sense? Okay. Okay. In another study, this is also in early stage breast cancer. This was from Melinda Irwin, published a couple of years later. This is now the same kind of plot that I've come up. So this is women who are, where's my cursor? There we are. I'm going a bit crazy. There we go. This is women reporting nothing. This is women reporting just a little bit of something. And you can see in this particular study, just doing something was associated with a significant drop, about a 60% reduction in the risk. Those women doing moderate amounts, about the same. Those doing high, it actually went back up, and then it went back down for those doing very high amounts. What do you do with this? What do you do with this? I bet you've never heard anybody talk about data like this. Like, what do you do with that? This is the ugly data that researchers don't talk about, right? Like, what do you do with that? So if I was designing a study today to look at the role of exercise to reduce recurrence in breast cancer, I would challenge you, what exercise dose would you pick? I would say is you could argue maybe various weights for various doses, but we don't really know. And I'm just providing two studies here, but if you actually look at all the studies in breast cancer, the actual range that's associated with a reduced risk of breast cancer ranges from about an hour of exercise a week up to about 8 hours of exercise a week. The other thing I should mention, all this data is actually asking women about their exercise behavior at one time point, at one snap point. I might ask you, 6 months ago, how much exercise were you doing? You take that level of exercise, and then that's what we're using to actually look at this dose-response relationship. No study yet has actually looked at the amount of change in exercise that you need to have an impact on recurrence. All you guys are going to hate research now, aren't you? I know, I can feel it. And again, there's not this linear relationship. More is not better. It appears to be this U-shaped relationship. There appears to be a threshold, maybe, of exercise. So again, what dose should be selected? So I think what's also important when we think about exercise is context. We rarely don't think about this, but in individuals without a history of cancer, typically when we give an exercise dose, the body has enough reserve capacity to really be able to tolerate that dose and actually adapt to that dose. That's why exercise is so good. The body, we're genetically programmed to exercise, but when we exercise, the body responds to it, it adapts. So that's what happens in individuals we know that, in athletes and things like that. But of course, in the context of cancer, there's a lot of stuff going on, right? There's not just exercise. You guys know this better than I do, that, you're having problems with sleep, you're going through treatments. There's a lot of, your immune system is all over the place. There's a lot of oxidative damage. My point being that you just can't apply research that we see in healthy individuals and say, well, this is what we think is going to work in oncology. Because we know from the research we've done, the physiological response is very, very different because treatments can have an impact on your normal physiologic response to exercise. And I'll talk about that in a second. But just want to make the point that it's not always apples to apples. It's sometimes apples to oranges. The other important thing, and I'll get into this a little bit later, but often I get the question of, what is better? Is it better to do low intensity exercise, moderate intensity exercise, or high intensity exercise? So the big wave right now, as you probably know, everyone's talking about something called HIIT training, high intensity interval training. Do 3 minutes of exercise per week, and that's the equivalent to doing like 4 hours a week. You see those articles all the time. I don't believe in that, to be honest. So the question is, what should I do? Should it be low, moderate, high? I can tell you the answer to this is all of them. And I'll get into this a little bit. When we look at our exercise prescriptions, it actually is exercising at low, moderate, and high doses that you get the optimal response in terms of your physiology. It's not just one or the other. It's actually a combination of all those things. I'm going to get into this a little bit later when I get into some exercise prescriptions, but I just wanted to make the point that most studies just look at that middle figure, just moderate intensity exercise. That's what we test in 99% of all studies, but we think it should be dosed a little bit differently than that. Okay, so doses associated a higher variable. Oh, sorry about that, guys. Getting ahead of myself. Come back. Sorry, gonna have to go through this all over again. All right. Okay, so the doses are quite variable. I don't think we can inform doses from these observational studies to then test in clinical studies. It appears to be this nonlinear, but I think we need to really elucidate what the most appropriate dose of exercise is in these studies. Again, I'll just pause right there and see if we've got any questions. Do we have any?
Well, one question that we've gotten in a number of different ways is that when you're coping with a diagnosis of metastatic cancer, you have a lot of fatigue and can be really hard to get the physical or the emotional energy to exercise. And I'm wondering how your institution supports people with metastatic breast cancer who want to be able to exercise but really don't know how to get started with it.
Yeah, the honest answer to that is MSK might disagree with me, but we and just to be honest, we don't. And so I run a research program. So the only way really that you can get a structured exercise prescription if you go to Memorial Sloan Kettering is if you're eligible for one of our clinical trials. There's nothing that occurs outside of that that's clinically available. Now, I get referred a lot of individuals from our docs, and I'm more than happy to work with everybody, but it's kind of off protocol, if you will. My job, I see as part of my job, is to create the evidence that exercise should be part of standard of care. That's my job, is to put myself out of a job, if you know what I mean. But we're not there yet. We're not there yet.
My follow-up to that would be, in your view, is that fairly common if people want to exercise? Can their medical oncologists support them in figuring out how to do that, or where can they get the information to support their patients who want to do that?
I mean, our oncologists are fantastic, but they're not exercise physiologists. Just like the same way I'm not a medical oncologist. I would say our oncologists are pretty good to saying to individuals, we think exercise is good, but that's kind of as far as it goes, unfortunately. I would say if people are interested, email me. Yeah, and I'll get into that a little bit. Not as though I have all the answers, but anyway. Okay, let's shift gears. Okay, how does it work? This is going to be a bit of a shorter section because I can tell you right now we don't really know. we hear about the benefits of exercise for a lot of different things, but I can tell you we don't really understand how exercise works at a cellular and molecular level. We don't. The way that we do think about this is cancer as an ecosystem. I think a lot of cancer treatments that we have focus on cancer cells. They don't think about the environment in which the cancer cells are surrounded. So think about all the treatments that you get. They're designed to kill cancer cells. And you probably think, well, that makes sense. But it turns out that all these other normal cells that are surrounding cancer cells really help cancer cells live and proliferate. And of course, within the breast or in the bone or wherever, that is not just isolated, right? That exists in a larger body. So if you think about it, when we think about the way that we are thinking about treating exercise, it's about treating the body, treating the whole person, not just treating those cancer cells, because those cancer cells thrive within a particular host system. So exercise is one of the few interventions that we have that treats the whole person, treats the physiology of the whole person. So that's what the way we're thinking about it. So we think about this as an ecosystem, an exercise as an ecosystem treatment. So that's how we're thinking about it. Now this is a very complicated slide. Not really going to go into it too much, but just to say that when we take individuals who have been completely sedentary for 20 years and we get them exercising in our clinical trials, lots of things happen. Lots of things happen. You get a lot of communication between what's happening in your bone, what's happening in your brain, what's happening in your heart, and essentially you're changing the ingredients of your body. As you start to exercise, things like insulin levels go down, glucose levels go down, your immune system gets better, the amount of oxidative damage in your system reduces, the amount of inflammation goes down. These are all factors that have an influence on cancer cell growth and development. So when we think about this, we think about all these changes that can impact this, the tumor microenvironment. So let's have a look here. OK. So I'm just going to take you back to a little bit of animal research. And this was a study I did when I was at Duke a few years ago now. But I think it's kind of interesting. We asked the very basic question is we took this was a triple negative breast cancer cell line, and we exposed them to exercise or not. You don't really need to understand the graph on the right. Basically, that's showing that exercise had no impact. Exercise did not slow the growth of these tumors, which we've since replicated. What was interesting about this is rather than just measuring these tumors, when we looked at these tumors from exercise versus control animals, they looked different. They looked different. And I remember looking at this. I'm not a pathologist. I'm like, these tumors just look different. And so what we did is we did something very basic. We looked at the number of blood vessels that were in tumors from exercise mice versus those from control animals, those who didn't exercise. And the number of blood vessels in exercise tumors was about 6-fold higher in the exercise versus the control. And you're probably sitting there thinking, isn't that exactly what we don't want? We don't want more blood flow and things like that into tumors. We actually want less of that. But that was very interesting. So we then did another experiment. This time, instead of just looking at the number of blood vessels, we actually did MRI scans of these mice. And we could look at the amount of blood flow that was going into these tumors. Now, I'll just go over here. So this is a control tumor here. This is a mouse that has been assigned to a control group. And you can see they don't light up very much. Like blood flow into tumors is not very good typically because blood vessels within tumors are very inefficient. They don't work very well. They try to work very well, but they just fail. They don't do very good. But in the exercise mice, the tumors lit up like light bulbs, significantly increased blood flow into these tumors. Now I'm going to go on the story. So with this, we then looked at the number of blood vessels. So this is obviously control versus exercise. Significantly increased blood vessels in exercise mice. We then looked at the function of these blood vessels. Were these blood vessels working better? And it appears that they were. But the final thing that's really important is we looked at the levels of hypoxia in these tumors, which is basically the levels of oxygen that's getting into these tumors. Now, hypoxia, low levels of oxygen, is a significant driver of aggressive cancer. So they don't like, so when tumors are growing, they get all these different areas of hypoxia, and cancer cells really hate that, so they try to get away from it. So it really makes the cancer cells aggressive. And what we found is in exercise conditions, the rates of hypoxia were significantly reduced with exercise. Now, this will become important in 2 seconds. So if you look at a picture of cancer, and this could be breast cancer, it looks very different. So the green, this is a picture of a cancer. So the green represents area of hypoxia. This is areas of low oxygen within a tumor. And it's very heterogeneous across the tumor. So this is areas of low oxygen. Does this all make sense so far? Okay. The red represents blood vessels. That's the red. The purple represents chemotherapy. So as you know, we deliver chemotherapy through the blood vessels. So we're very good at getting chemotherapy very located where these blood vessels are. That makes sense. But we do a lousy job of getting chemotherapy into these hypoxic areas. It doesn't go there. So these cancer cells that we want to kill are protected. They're protected. Now, so you can imagine, if you know that exercise is reducing those areas of hypoxia, that raises the intriguing question, what if we combine exercise with chemotherapy? Will that make chemotherapy work more effectively? And I can tell you, we've done that. So we've only done it in mice, though, so far. So what we did is an experiment. This is in a breast cancer cell line. We took these mice and we randomized them either to a control group, so that was just sitting on the treadmill by themselves, or exercise. In this case, it was wheel running, so we put them on a wheel. If you put a mouse on a wheel, you turn the lights off, it'll run between 3 to 6 miles a night. Mice just love to run. They love it. They love it. The third group got chemotherapy only. In this case, it was cyclophosphamide. The fourth group got exercise plus chemotherapy. Here's the data. I'll walk you through it. OK. So this is tumor growth, how fast these tumors grew. The gray represents the control group. So those tumors grew the fastest, as you would tend to expect, because they were getting no treatment. This is a little bit hard to see, but the gray square is chemotherapy only. And that's hard to see because exercise is right on top of that. So chemotherapy only reduced the growth of these tumors. As we know, chemotherapy works. But exercise alone was just as effective as chemotherapy. Now, please don't walk away from here saying that Lee Jones said just to exercise, not to take chemotherapy. I'm not saying that. I'm not saying that at all. But it's interesting. Of course, what's most important is what about the combination? And the combination of exercise with chemotherapy was associated with the slowest tumor growth. So again, it appears not only exercise by itself, but it also might help chemotherapy work better. And we think the mechanism of that is because of this lowering of hypoxia, getting more chemotherapy into these tumors in the first place. I'm going to skip this slide. We did look at this in people, but we didn't do the study very well, so I'm going to skip it. OK, so exercise changes tumor physiology. OK, I went a bit. Exercise changes physiology. This might be the reason. I think with that, you also get changes in things like metabolism and immune infiltration into these tumors. But also, we might actually improve the efficacy of conventional forms of treatment as well. So I'm going to stop there. I think it's a good place to pause. And do we have anything?
Yes, we have a number of questions and observations. First, a number of people have texted to share that Livestrong and the Y do an exercise program that's specific to people with cancer. So that's definitely a resource for folks. Our first question is, do any of these studies look at the relationship between diet and exercise? Typically, people who exercise may have better dietary habits. Could exercise benefits be attributed to both, or is it just the exercise?
Yeah, it's a good question. I mean, there are some animal studies that have done caloric restriction with exercise, showing that both appear to be about equally beneficial. The combination tends to be a little bit better, but it really depends on the endpoint. Nobody's done clinical trial yet to really look at that question, I would say, in the way that the animal studies have been done. But I do agree with the fact that people who are exercising could change their diets. I'll talk about it in a second. We do monitor dietary recall in all our clinical trials to see if it's changed or not as exercise training. But I'm only I only know about exercise. I don't know about nutrition, so that's what we've stuck to.
Sure. Our next question comes from someone who had read about a study conducted in Western Australia where people were getting cancer treatment. They would exercise right before treatment. Then they would go have their treatment. And the people who exercised immediately before had better outcomes than people who did not. Are you aware of that study or know of similar studies happening in the United States?
I am aware of that study. I don't think that study showed that improved cancer outcomes per se. It might have shown that improved blood flow to the tumor. I don't think it showed that that was associated with better outcomes yet, but I think it was if I remember the study correctly, I think it was a proof of concept type study to see if even that was possible to exercise somebody right before their treatment.
Great, thank you. So I have a number of questions and comments about including people with metastatic breast cancer in exercise studies. Would you like to address that? Great.
Okay. Does everyone just want to take a stand for 30 seconds? Just stand up 30 seconds. You've been sitting for a long time. I know I've been pacing up and down. No, I'm not going to make you exercise, but don't worry. Unless you want to, of course. Okay, guys, that's it. I'm afraid. That's it. Sorry. Back to learning. Okay. We okay? We doing all right? Yep. Caffeine's not wearing off? We're okay? All right. Okay, we're in the home stretch. We're in the home stretch. Believe me, you'll get rid of me soon enough. Okay, so I think I've presented some data that if you look at these different steps, I presented some epidemiologic data, some molecular epi data suggesting that the relationship is different as a function of biology, some preclinical data. So now I'm going to get into I think some of the trials, and we've done lots of trials over the past 20 years or so. I'm just going to concentrate on some of the studies that we've done in the context actually of metastatic breast cancer. So safety and feasibility of exercise. I know we often think that exercise is safe for everybody, it's feasible for everybody, but we really wanted to test this. And I think when it comes to metastatic breast cancer, we can't apply the research we've done in early stage breast cancer or any other type of condition actually. So we really wanted to test it in that context. So this was a study that we've actually finished about 6 months ago, and we published it fairly recently. I think this is the first exercise study ever in metastatic breast cancer, to be honest. So we started very simple question. So this was in 65 women who could have any subtype of metastatic breast cancer. It could be on any line of therapy. They could have been first line, they could have been 6th line therapy. We took everybody. Anybody who wanted to exercise, come into the study. They could have had any prior treatment, but they all had to be inactive to get into the study. All had to be reporting less than 90 minutes of exercise per week. And you're probably saying, Lee, why is that? Well, we want to intervene with exercise on individuals that are not currently doing it, right? That makes sense. You wouldn't give a blood pressure medication to somebody whose blood pressure was fine. That wouldn't make any sense. So we think about exercise in the same way. And this was a hard message to get to our oncologist. Like, Lee, I've got this person who loves to exercise. They're doing all these things. They want to come into your study. I'm like, they can't. They're too active. Which is actually a great thing to tell somebody, by the way. So what we did, we took these women and we did a bunch of physiological assessments before the study happened. So this was a peak exercise capacity test. This would be taking somebody to their maximal exercise capacity. We looked at their heart, we looked at their lungs, we looked at their muscles, looked at body composition, we did patient-reported endpoints, did a whole bunch of physiological assessments. These individuals then got assigned either to what we call an attention control group. which we brought these women. So most exercise studies say you get exercise or you get nothing. We didn't like that so much. So the women who got randomized to what we call to our attention control, all these women came in and did progressive stretching. 12 weeks, 3 days a week. So they came into our fitness center and they got the same amount of attention as individuals who are in the exercise group. The exercise group, this was all treadmill walking. This wasn't running. It was all treadmill, on a treadmill. So all our exercise capacity testing was on a treadmill. This was 3 days a week, between 60 to 80% of someone's baseline exercise capacity. So I'm not going to get into this too much, but we personalize the exercise prescription. So not everybody gets the same exercise prescription because everybody's a little bit different. Everyone's physiology is a little bit different. So you measure your fitness, and then the exercise prescription is designed on the basis of your baseline fitness. But for everybody, that ranged between 60 to 80% of capacity, so moderate to kind of higher intensity exercise. Each session was anywhere from 20 to 45 minutes in duration for 12 weeks, 3 days a week. And every exercise session, you had to come into our facility at 68th and 1st on the Upper East Side, and every session was one-on-one monitored by our team of exercise physiologists. When I talk about exercise, that's what I'm talking about. Physical activity is everything else. That's exercise. At the end of the 12-week intervention, we repeated all the assessments. So I'm going to go through the study quite fast. So I can tell you, first thing, what was most important, exercise was safe. We did not see any serious adverse events with exercise. Now, you might say, well, exercise is safe, but I don't think people have done a very good job of actually monitoring or measuring safety. So that was the first important thing. Like, nobody had ever done it in this context before. So we said it was absolutely safe, but it wasn't feasible for everybody. Not everybody was able to exercise 3 days a week, as you can probably know. So what we did is we set the level of feasibility of, we had to see a mean attendance rate of about 70%. So on average, we wanted individuals to come about 70% of the time. We thought that sounded reasonable. So individuals who are not able to come in all the time, we monitor every single time that they come in. And what we found, overall, the attendance rate was 67%. So it was just under that. So we concluded it wasn't feasible for every single individual. So we said we did, so I think I was just the first study to say that exercise wasn't feasible for everybody. But that's important. We also looked at the number of times we had to modify the dose of exercise. So just like with treatment, you have a planned dose that you're going to get that particular day, and then there's the actual dose that you get, right? You might not get the full dose because you're fatigued or your blood levels, your blood counts aren't quite there. So we do the same thing with exercise. And what we found, we had to modify the exercise prescription 50% of the time. So this is really important. This is why the one-on-one is so important, because we had individuals who come in that particular day and they could only do half of the prescription. If I just send people home to do, I never would have known that. So we had to modify it about 50% of the time to make individuals, make sure, of course, our primary concern, to make sure that it's safe. About half of the individuals randomized to the exercise group, exercise was very tolerable. It was very feasible. In fact, the mean attendance rate in those individuals was like 90%. They hardly missed a session. And so we looked at the characteristics of those individuals in which exercise was safe and was feasible. And it looked like it was those women either getting first or second line therapy, as you tend to expect, had good performance level coming in. And so those the individuals. So this study was really designed to ask that question. What is the basic feasibility? And who are the individuals within this context, even though there's a lot of variability, who can come into one of these types of pretty intensive exercise? So on the basis of that, this is very slow. On the basis of that, we now have a second study that's just about to start. We just got this funded through the government. So these are hard studies to get funded, which we're very happy about. So this is kind of like the phase 2, if you will, in metastatic breast cancer that builds on our prior study. So this is a phase 1A study. You probably heard about phase 1 studies with drug trials. The purpose of those studies is to identify what the maximal feasible dose of the particular drug is that's safe. We're doing the same thing with exercise. As I mentioned to you, we don't know what that dose is, so we're going to try and find it. And we're going to try and find it for women with metastatic breast cancer. So these are all women either getting first line or second line standard therapy. Again, all have to be inactive to go into our study in the first place. and you have to have oncologist approval to get in our study. We do, again, the same types of physiological assessments, and then women are assigned either to 150 minutes of exercise per week, 225 minutes per week, or to 300 minutes of exercise a week. That's a lot of exercise, by the way. And we're trying to identify what is that dose. Is it 300? Is it 150? Are there certain characteristics of individuals who can do 300 but not 150? So we're going in completely unbiased, and we're going to figure that out. That's what we want to do. That's the primary purpose of the study. And then we're going to do what we call a dose expansion. So we're going to identify the dose that we think is the most feasible, that also has biological activity. And what we mean by that is we're also going to look at tumor progression from baseline to 6 months. We're going to pick the dose of exercise that is feasible and appears to have benefit in terms of tumor endpoints. And then we're going to do a second study where we test that dose in another cohort of individuals, a separate cohort. And the whole purpose of this study that's going to take 5 years is to identify what we call the recommended dose of exercise for then test in a larger randomized controlled trial. So again, we're trying to take that drug approach to the study of exercise. This study just got funded, just got IAB approval last week, so this is going to start in the next kind of 2 weeks or so. The other exciting thing about this is we're also going to take this multi-site. So most of our studies to date have been all single-site at MSK, but we're going to be working in something called the Translational Breast Cancer Research Consortium, TBCRC. And we're going to look to take this trial outside of Memorial to other cancer centers, particularly on the eastern seaboard. Okay. Any questions? Okay, this is the final push.
We only have a couple more minutes, so just go ahead.
Okay. I've talked a lot about exercise, but I haven't really talked about what that means to us. So every individual coming into our studies, we do this exercise assessment that involves many different steps. And we've only got a couple minutes, so I'm going to skip through some of this. But essentially, we measure somebody's physiology, and then we use that information to design an individualized exercise prescription. And then, of course, if we do that, we want to be able to deliver this prescription in a rigorous manner. So what we do, we can either bring individuals into our center in Manhattan. Everything's one-on-one. And this is great if you live on the Upper East Side of Manhattan. Most individuals don't, as you can imagine. So what we've created is something called our TeleX solution. This is, our map's not showing up, but I'll basically just walk you through. We now own a fleet of 50 treadmills. And what we do is we ship these treadmills to the individual's house. Each treadmill comes with an iPad, some other wireless devices, and then the iPad sits on top of the treadmill, and we monitor the patients one-on-one every single session using video conferencing, like FaceTime. So every session is still one-on-one with our team of exercise physiologists, but now they could be exercising at home anytime, Monday to Friday, 7 to 7, with all my exercise physiologists sitting in Manhattan. So this is happening right now. I can tell you we've now taken this to the next step, where we can monitor multiple patients at multiple locations at the same time with one exercise physiologist. We call this our virtual training space. 6 patients at a time exercising in different locations. And then the final part of this, we've taken this now to the next level, and hopefully you'll appreciate this, is what we call our digitized clinical trial, where most of the time for clinical trials, you have to schlep into the center, you have to sign consent forms, come for the assessment, come for blood draws. We flip that on its head. We now e-consent patients at home remotely. We send the treadmill to their home. We do the exercise capacity assessment in their house. We send them, of course, they got the treadmill to the exercise sessions. We send them home with a bunch of devices, and we do wireless monitoring of sleep, physical activity, glucose, weight, and blood pressure every day. That comes into our cloud. And then we actually send a company to the patient's house to get all our bloods and also get stool, because we're interested in how exercise is changing the physiology of the body. And so you never need to come to Memorial ever to be on one of our clinical studies. All this comes in wirelessly into our cloud. This is happening right now, by the way, guys. So we can pull off all the information off the treadmill in real time through a cloud. Again, we get mobility, we get sleep. We also take, for your diet, we actually just take pictures of your food, and that will tell us the caloric content of those food using something called BiteSnap. And then we're getting all this other information in terms of heart rate, weight, blood pressure, and that kind of stuff. How long do I have? We're done? Okay. So I'm just going to finish with this. And I do have some slides that actually talked about prescriptions as well, but you maybe just come up to me afterwards. So I think conventional wisdom is that exercise improves cancer treatment and outcomes after a diagnosis. I would say I believe that is true. We don't quite have the data yet, but we're really working on it. We're working on it right now. I'm working on it this morning on the train. Exercise is equally beneficial for everybody. Hopefully I've proven to you that that's not true. I'm not saying that exercise is not beneficial for everybody, but I think everybody needs something slightly different. Just in the same way, if I was an oncologist, I wouldn't be standing up here saying that everybody needs the same type and dose of chemotherapy, because you'd think I was crazy. But that's what we do with exercise, and we're looking to blow that myth out of the water. Then everybody should exercise according to the guidelines. I don't think that's true either. We need to personalize exercise based on what treatments, your biology, and your physiology to get the optimal response. So with that, thank you again for the invitation. Thank you for listening, and thank you for attention.
Thank you so much, Dr. Jones. And I can tell from all your text messages, and I'm sorry we weren't able to answer everyone's questions, but there's so much energy and enthusiasm for this kind of research. So, and to be able to begin to make exercise more tailored just the way we're making our cancer medicines more tailored. So we're going to take about a 10-minute break now, even for our folks on the live stream. Please join us back at 11 o'clock for Dr. Pop's session on living well, managing symptoms and side effects. So you can go stretch your legs and take a walk. Take care.